Sherry, yeah, Sherry, I'm going to turn it kind of over to you to get us going, and then Dr. Eads.
Okay, I do have slides, Sherry, if you want me to,
Okay.
share.
Okay, I think you can share now.
Okay.
Oh, yes.
Let's see here. Okay, can you all see that?
Yes.
All those slides? Okay. I would first like to say thank you very much to Sally and her co-leaders of your group for inviting myself as well as some of the rest of our neuroendocrine team here today to speak with you. I'm very excited to meet all of you. As Sally mentioned, my name is Jennifer Eads. I'm one of the medical oncologists at the University of Pennsylvania, and I specialize in the treatment of patients with neuroendocrine tumors and lead up our neuroendocrine program. I just want to introduce, you'll meet them later also, but on the line today as well are our two nurse navigators for our program, Bonnie Bennett and Diane Boyd. So there will be an opportunity to ask me questions, to ask them questions at the end. But essentially what I thought we'd do and what Sally and I had talked about was sharing the clinical trials that we currently have going on at Penn, and then talking a little bit about our neuroendocrine tumor program so that you all are aware of what's available. It's difficult to kind of just dive into what clinical trials are available without a little bit of background in terms of how we go about managing this disease. So probably we're going to be focusing primarily on people who have metastatic disease, as well as disease confined or largely involving the liver. But if we think about patients who are diagnosed with a neuroendocrine tumor, those who have a localized condition generally undergo surgical resection. We remove it and we're done, hopefully. There are then people who have some element of metastatic disease, but it's relatively limited. So we feel like we can still do a meaningful surgery. So we do try to remove everything surgically via a debulking surgery. It may or may not be curative, but it definitely can reset the clock for people. And then, like I said, the areas that we'll be focusing on the most are patients with liver dominant disease. So those are patients who have the majority of their tumor confined to the liver, if not all of it. And for those patients, liver-directed therapy is often an option. And then finally, metastatic disease, where the standards include several things at this point, kind of depending on if it's a pancreas primary, a bowel primary, or a lung primary. But those include somatostatin analogs, targeted therapies such as everolimus or sunitinib, chemotherapy, or PRRT. And of course, we always want to be considering our clinical trial options because that's how we learn more about what treatments may be appropriate for patients and have the opportunity to offer new therapies to patients. So we're going to start off with liver-directed therapy, and essentially this is a procedure that is recommended by all of the major societies. So the North American Neuroendocrine Tumor Society, the European Neuroendocrine Tumor Society, and then also the National Comprehensive Cancer Network. And basically, it's recommended that an embolization therapy of some sort be administered to patients who have disease progression in the liver or symptoms in the liver, where the majority of the cancer is involving the liver. So there are several approaches to how one might do this. There's a picture here. Essentially what this procedure is, for anyone who has not had it, is we, or an interventional radiologist performs this procedure and goes into a blood vessel in the groin area that goes all the way up into the liver, where the tumor is present. And then there's this injection of, this injection of beads into the liver, where the beads then get stuck in the tumor and cause a localized killing effect. So those beads that can be injected include those that are labeled with chemotherapy, so chemoembolization. It can be labeled with radiation therapy, which would be radioembolization. It can be a bead that does not have anything on it, which is referred to as bland embolization. Or there are beads that sort of elute drug, where medicine comes off of the beads. And so those have been the four general approaches. This has not been a well-studied area at all, so there's really not trial data to guide what is the best approach for people. So it tends to be institution dependent. And I will say that we have been backing off a little bit more on radioembolization, only because we're not sure how that might interfere with the radiation therapy from PRRT down the line. So we are cognizant of that. But we do have a trial at Penn. This is the Retinet Trial, and this is led by our interventional radiologist, Dr. Michael Sulin. And basically what that stands for is randomized embolization trial for neuroendocrine tumor metastases to the liver. And they are looking at, basically trying to figure out which of these embolization modalities is the most effective for people. So is one more or less effective? Is one more or less toxic? And does one provide a better or worse quality of life? This study is ongoing. There were 4 out of 10 patients in the initial drug-eluting bead arm who had major complications. And so that arm was closed, and that added to some prior literature. And so as a result, that's actually changed the NCCN guidelines, and drug-eluting beads are not used so much at this point. But accrual to this study is still ongoing, looking at other modalities. And so we're hoping this will be the first randomized trial to really evaluate what form of embolization therapy seems to be the best for patients. So then now we're going to move on to the trials that are in metastatic disease of a non-interventional radiology nature. And this is really where the majority of trials often lies, because these are the patients who need a treatment. And so in order to understand some of them, we need to first understand a little bit more about the tumor itself and the role of the somatostatin receptor. So the somatostatin receptor is expressed in anywhere from 80 to 100% of pancreatic neuroendocrine tumors and carcinoids. And so this is a receptor that's present on the cell surface of the tumor cells. There are 5 types of these receptors, and the higher the number of receptors that someone has, and the more diverse the types of receptors present on the cell, that's generally consistent with the slower growing, more well-differentiated tumors. And what this correlates into is findings of a positive either octreotide scan, or more commonly now, the gallium dotatate PET scan. So that scan relies on the presence of the somatostatin receptor on the surface of the cell in order to get a signal. So what's being injected is essentially a radio-labeled octreotide type molecule that then goes to find the somatostatin receptor. And if it's present, then it will light up there. And so that's how we know that the cells have the presence of those receptors. And this can serve both diagnostic and therapeutic purposes. So the diagnostic purpose being, that you get a gallium dotatate PET scan and we can see the distribution of the disease, but a therapeutic purpose in that we can also use it to actually target treatment. So this is how PRRT works, which many of you may be familiar with. So basically what we have is this radiopeptide, okay, so a molecule that contains radiation. And what happens is that it binds to the receptor on the surface of the cell. So this is the somatostatin receptor, and it gets internalized, and then the radiopeptide gets released inside the cell where it causes this localized killing effect. And so because these somatostatin receptors are only present on the surface of the tumor cells, that's how we get like localized delivery of this radiation therapy, as opposed to it, acting on all cells in your body because of, a receptor that could have been present all over. So this is more specific. So as many of you know, PRRT has been, approved in this country for treatment of metastatic gallium positive PET scan. I mean, you basically have to have a tumor that's positive on gallium imaging, and it's a highly effective therapy. And so with this, people have capitalized on that presence of the somatostatin receptor to provide localized delivery of other agents. So one of the trials that we have had recently and has closed, I know some of you have attended our patient care conference and maybe have heard me talk about this before. I thought it might be, nice to also give people updates in terms of like what's happened as we've gone along. So we had a trial at Penn. This was a phase 1 study of a somatostatin receptor and CD3 bispecific antibody. So that's an antibody that binds to two things that essentially allows immune cells to be drawn to neuroendocrine tumor cells. And it sort of triggers this localized immune attack on the cancer cells. So you can see from this picture that you have an antibody that's got one arm that binds to the immune cells and then one arm that binds to the tumor cell, so CD3 and then somatostatin receptor, and it allows those cells to come together so that you can get a localized immune attack on the cancer cells. So this study involved patients who had a grade 1 or 2 neuroendocrine tumor of the pancreas, GI tract, or lung, who had progressed on at least a somatostatin analog and one other targeted agent. And patients received this medicine on a weekly basis and were followed with imaging. And, really the goal of this study was to look at safety and toxicity and to figure out the dose that was the best, but to also look at how many patients responded and how many stayed free of further tumor growth for some period of time. So this study has completed, and the results are being analyzed, and I'm not able to present results today. I believe it is going, to potentially be presented at an upcoming meeting, but we're not able to, talk about the results. So once those are public, we can certainly share them. So that's exciting that study was able to fully accrue and, finish. And now we're waiting for results. And I've been in communication with Xencor about the possibility of a follow-on study where we might look at the combination of this medicine in combination with like another immune drug, so that you could potentially get a more enhanced immune effect. But I think that is still like in the works because they want to do a little bit more following of the patients who are on this trial first. So along similar line of capitalizing on that somatostatin receptor, another study that we had at Penn that has now closed was with Tarveta. This was a study of a somatostatin receptor ligand that was linked to DM1. So DM1 is a chemotherapy. And so what this was going to allow for was for localized delivery of chemotherapy directly to neuroendocrine tumors expressing the somatostatin receptor. And they had actually found in their earlier studies that the patients who have a carcinoid tumor or a bowel net were having better outcomes than patients with a pancreas primary, which is uncommon because we usually use chemotherapy in pancreas patients. So I was actually very excited about this because it would be great to have a chemo option for bowel net patients. And so patients for this study included those with a neuroendocrine tumor of the GI tract who had progressed on a somatostatin analog and a targeted agent. And they received this medicine intravenously, and then again were followed with imaging. And the goals of this study were to determine safety and toxicity and determine the best dose, but to also look at efficacy. And so similarly to the prior ZenCore study, this trial has been completed and we're waiting for the results. And once this, once the results are available, the hope is that we will have a subsequent trial of this agent that potentially, compares it to another medicine that is used for treatment of neuroendocrine tumors. So we'll stay tuned on that one. And then, moving into the studies that we have, coming up or currently, I thought we would talk a little bit about the role of targeted therapy in neuroendocrine tumors. So the medicine everolimus, which is an mTOR inhibitor, is an oral medicine that has been approved for treatment of both pancreatic neuroendocrine tumors and bowel nets. And this medicine helps, keep things from growing for on average about 11 months. It generally doesn't shrink things too much, but it can keep things stable. Similarly, sunitinib, which is a different targeted agent that is a VEGF inhibitor, has been approved for the treatment of pancreatic neuroendocrine tumors, and it has relatively similar outcomes as the everolimus with preventing tumor growth for about 11 months, and then a relatively low rate of tumor shrinkage, so only about 10%. But the more exciting one that's sort of coming along is a medicine called surufatinib, which targets multiple receptors. So this is the vascular endothelial growth factor receptor, the fibroblast growth factor receptor, and then colony stimulating factor, stimulating factor 1 receptor. And it similarly has had findings in earlier studies of holding off tumor growth for around 11 months, but more patients tend to respond to it. And it has been actually approved for treatment of both pancreas and bowel nets in Asia. And we're working on an approval in the United States. So to build on that study, we have a trial that is newly available. This is the Hutchinson trial. We'll be starting the phase 2 element of this study. It's surufatinib in combination with a medicine called tislelizumab, which is an immunotherapy agent in people who have advanced solid tumors. And they are evaluating multiple tumor types, but most pertinent for us has been, the neuroendocrine tumors, but patients with colon cancer, gastric cancer, small cell lung cancer and sarcoma are also allowed to participate. So patients in this study need to have a grade 1 or 2 neuroendocrine tumor of the bowel, pancreas or lung, and have to have progressed on at least one line of therapy. And then will receive surifatinib, which is an oral medicine given once a day. Sorry, I'm not sure what that background noise is there. So patients will receive surifatinib orally once a day, and then tislelizumab, which is the immunotherapy agent, intravenously every 3 weeks, and then will be followed with CAT scans to evaluate response. And so what this trial is really looking at is to see how many patients have a meaningful response, and whether or not, it helps to prolong either the time to tumor growth or overall survival. So this one is newly available for us. The other study that has just recently started is the CAPTEM and Y90 trial. So this one is led by Dr. Sulin in interventional radiology. I will say the prior Hutchinson trial is mine, and this study is based on the hypothesis that the use of chemotherapy along with Y90 radioembolization results in an enhanced effect of Y90. And so what this trial also does is that it allows for people with liver dominant disease to get both liver-directed therapy and systemic therapy for the treatment of the rest of their cancer. So this study allows for patients with a grade 1 or 2 neuroendocrine tumor of the GI tract, pancreas, or lung who are appropriate for liver-directed therapy. And then they start on temozolomide and capecitabine chemotherapy. And during that time, we do like a planning procedure in radiology for preparation for the Y90. And then after patients have gotten through that first cycle of chemotherapy, then we start the Y90, or we do the first procedure of Y90 during the second cycle of chemotherapy, generally on day 7. If a patient is going to be needing radioembolization to the other side of their liver as well, that generally follows about a month later, as long as patients are doing okay. And then the chemotherapy continues. So this is going to allow us to assess how tumors both within the liver and outside of the liver respond to this therapy. And we can kind of, see if that seems to be better than if you were to give either Y90 alone or temozolomide and capecitabine alone. Now, we're not doing a direct comparison. We're comparing to historical data, but the idea being that if we see a big difference, that ultimately we could do a comparative trial. So the next study that we're going to talk about, and I know one that has been a topic of great excitement amongst the neuroendocrine community is CAR T therapy. So Dr. Waugh, I think I'm not sure if he's spoken at this group before, but you may have seen him at our patient care conference. He is a basic scientist who has been working on CAR T therapy and neuroendocrine tumors for some time in the lab. And he has identified a target called CDH17 that is a marker that's present in about somewhere around 50% of pancreatic neuroendocrine tumors, and then over 90% of bowel mets. So it's present in a lot of these tumors. And from his research in the lab, what has been demonstrated is that there seems to be a pretty significant treatment effect with this CDH17 based CAR T therapy. So it is a marker that's also present on some other GI cancers, so colorectal cancer, gastroesophageal cancer, and pancreatic cancer. And so we are at a point now where I think we're going to be able to go ahead with a clinical trial in sort of multiple patient populations. So it will include neuroendocrine patients, colorectal, gastroesophageal, and pancreas. And we do have funding secured to be able to do this. So we're going to go ahead we'll kind of do an initial phase 1 study looking at dose, like what's the most appropriate dose for people. And then once that's been determined, then we'll sort of do these, what we call expansion cohorts. So a group of patients with each of these type of cancers to look at this further. So this is very exciting. And it's in the early stages, but it is coming along. The other drug that we're working on is called belzutifan. And this is a HIF-2 alpha inhibitor, which stands for hypoxia-inducible factor 2 alpha. I'm not sure if you all had seen, but it was a drug that was recently approved by the FDA for treatment of von Hippel-Lindau or VHL related tumors, which generally include renal cell carcinoma, hemangioblastomas of the central nervous system, and pancreatic neuroendocrine tumors. So the approval was for patients who had like a localized one of these tumors. So, whether it was a renal cancer or a pancreatic neuroendocrine tumor. But what they saw in the study, at least amongst the pancreatic neuroendocrine tumors, which is, what we're most interested in, was that there was a response rate of 83%, which is very high. And so now this drug is being evaluated in the metastatic setting for patients with both pancreatic neuroendocrine tumors and metastatic pheochromocytoma and paraganglioma. So we are working on getting this trial open at Penn, and hope to have this as an option. And this would be one of the first trials in a while that we've had for parapheo. So that's pretty exciting. And then finally, just to touch on high-grade neuroendocrine carcinoma. So definitely a rarity amongst the neuroendocrine tumors, but something that exists. It accounts for only about 10% of all neuroendocrine tumors. And so you're talking about a rare population. And as a result of that, it's a very hard disease to study. So there's very limited clinical trial data to really guide what we should be doing. Historically, it's been felt that this tumor was similar to small cell lung cancer. As we learn more about high-grade neuroendocrine carcinomas, we're seeing that's not really true. We're trying to figure more out about this disease. But historically, small cell lung cancer studies had shown that platinum and etoposide is the best treatment option, where somewhere between 44 and 86% of patients have responded to therapy and have, it has extended life, albeit short, with an overall survival of 8 to 11.4 months. There's never been a prospective trial that's been conducted in this population, and it's never also parsed out that well-differentiated high-grade population from the poorly differentiated high-grade population. That's a newer thing. So this study was EA 2142, which is a randomized trial in high-grade neuroendocrine tumors or carcinomas of the gastrointestinal tract, as long as patients had a Ki-67 of 20 to 100%, which is a marker in the tumor, or a mitotic rate of greater than 10 per 10 high-powered fields, which essentially both of those are indicators of a faster growing cancer. And patients in this study were randomized to receive either carboplatin or cisplatin in combination with etoposide or temozolomide and capecitabine. And what we're really looking to see in this study is whether or not progression-free survival is improved with the use of temozolomide and capecitabine over platinum etoposide, as we don't really know if that's even the right chemotherapy to be using for this disease. So this study, this was a national trial, and it has actually been completed. And so we're waiting for the results of this, but we had this open at Penn. And I, in full disclosure, I wrote this study. So we're waiting to see what the results of that are, and stay tuned for that. So that kind of concludes our overview of our clinical trial portfolio. I then just wanted to, let you guys know kind of what exists within the Penn Neuroendocrine Tumor Program. As many of you know, this was Dr. David Metz was previously at Penn and has since retired, much to our dismay. But our program is still up and running and fully functional, and I have been given the opportunity to take that over from him. And what I would really highlight about it is really our multidisciplinary group of physicians and support services. So we have people who are pretty dedicated in all of these areas. So medical oncology, surgical oncology, nuclear medicine, interventional radiology, radiation oncology, cardiology, endocrinology, genetics, nephrology, gastroenterology, pathology, and nutrition. So, we have our go-tos in all of these areas, and do a lot of regular meeting, and share a lot of patients amongst each other. It's important to know that you may not need to see all of these people, but you may have a few different physicians amongst our multidisciplinary group, kind of depending on what your particular situation is. And some of the key elements of the NET program that I just wanted to sort of highlight. Again, I think the key thing is that we have our multidisciplinary group of experts. And then these experts then, we meet on a weekly basis for our neuroendocrine tumor board, where, we discuss cases that, need additional input. So sometimes things are very straightforward in terms of what should be done for a patient, but oftentimes that is not the case. And so this gives us the opportunity to discuss amongst each other with everyone present at once to figure out the best plan for a patient. As many of you probably know, we have an annual patient care conference that for the last, the last year was held virtually. Ideally we hold it in person and are able to, meet with everyone as well. We have navigation for nursing navigation for streamlined NET care. So as I mentioned, Bonnie Bennett and Diane Boyd are with us on the call today, and they are our nurse navigators who help people, figure out who they need to be seeing. We have collaborative research going on. So we have the clinical trials that I just discussed. We have additional translational and basic science research that I did not include here in this presentation. And then, as an example of our collaboration, the CAR-T trial is sort of key to that. So, we had a basic scientist figure out, how to make CAR-T therapy work in the lab. And now we're trying to translate that into the clinical setting in the form of a clinical trial to evaluate in patients. And so, he and I have been working together, and that's a really great collaboration. We also have a pretty significant tumor biorepository, both for parapheo and for GI and pancreatic neuroendocrine tumors. We are continuing to expand that, and that is essentially a bank of tumor biopsies that we have obtained from agreeable patients over the course of time, and those specimens can be used for doing sort of pilot studies or early studies to figure out if like we might be on the right track in investigating a particular target. So it's really important for us to continue to replete those tumors because they get used up over time. And we're able to sort of query the biorepository for further hypothesis generation. We now have a dedicated cancer service line within the Abramson Cancer Center. So the neuroendocrine program has been given its own designation, which has some significant benefits in terms of that allows us to be able to perform quality improvement projects. So, things that could be better within net care or net research, we're able to do that. And we're able to make programmatic improvements, and it comes with funding. So we have some money behind us to be able to make some improvements to our program. And then recently, we were named a Center of Excellence by the Parapheo Foundation. So that was very exciting. And so in terms of, accessing the team, if there's ever any interest in seeing any one of us, as I've mentioned, Diane Boyd and Bonnie Bennett are the nurse navigators for the neuroendocrine program. And, they can be reached by email or phone. And, we're happy to see anyone who would like to come up for either, routine care, for second opinions, for clinical trial interest, you name it. So we're happy to help you in any way that we can. And I think that is my last slide. I wanted to leave enough time for questions and, you guys being able to talk with us a little bit. So, so I'm going to stop sharing my screen here, and we can see each other. And if there's any questions, I'm happy to answer, or if you have any questions for Bonnie or Diane.
Well, thank you very much, Dr. Eads. We really appreciated you sharing what you all are doing at Penn. A couple questions came in to me, so I guess if I can read them, let's see. And Sherry, these came from you. Her question is, if you don't have a solid tumor, what kind of other tumor may someone have?
Oh, so yeah, that's sort of a hemonc term. So sorry if I, spoke above. So we refer to hematologic malignancies such as like leukemia, lymphoma, sometimes lymphoma, multiple myeloma as liquid tumors. And so when I'm talking about solid tumors, we mean ones that actually like form a mass. So generally like, lung cancer, breast cancer, GI cancers, prostate cancer, but not leukemia or myeloma. Yeah.
Okay.
Those,
Sorry
those
about
more
that.
like bloodborne.
Blood, yeah. So those are basically like blood tumors. Yeah. So that's a whole different category of diseases.
Okay. And the next question also from Sherry is, she was curious as to what phase is the Retinet trial. Not sure if I heard that it was phase 2 or otherwise.
I believe it's a phase 2 study. I don't think it's a phase 3, but it's a randomized trial. So it's, it's at least a phase 2. And, for some of these rare diseases, it's difficult to do phase 3 trials because they just get too big, and these, these diseases are rare. And so it would take us forever. And so, a phase 2 study for this particular question that's being evaluated is, it's pretty good. And this is the first like randomized trial ever of any embolization therapy. So that's exciting.
That's good. Yes.
Yeah.
Folks, if you do have questions, if you could just put them in the chat, and either I can read them, or I guess Dr. Eads can see the chat. I guess something I didn't realize, I guess, are your tumor boards now meeting every week then?
They are. So, we had previously been doing it twice a month, but it became clear to us that we just have too many patients. And so we have transitioned that now to weekly, which I think has been a good improvement, both from the sense of, keeping our meeting to a reasonable time, but also, then we don't have to wait for an additional 2-week period to go by to put someone on. So I think we're able to, generally provide feedback to people a little bit faster. So, I think that's been a positive improvement.
Okay, a couple questions. Another question about the Retinet. Question was, when will the Retinet study be completed?
So, I don't know the answer to that question. I think, there are multiple sites involved, and we've done very well with accrual at Penn. And then there are, other sites that are still trying to, achieve their numbers for the study. So I think it kind of depends on when those are done. At this point, there's over 120 patients who have been accrued to that study. So it is pretty far along. But I could ask Dr. Sulin and see if he has any kind of speculation, but I'm not sure how much longer that one has.
Another question, what were the chemos used in the Tarveta trial?
So the Tarveta trial used this DM1. So it's not a chemotherapy that we use for any other GI cancer. I think they may use it in breast cancer, but that's probably why you haven't necessarily heard of it. But it's a medicine that, or is a chemotherapy that can be often linked to something else, and so that is how that study, with it being linked to that element that binds to the somatostatin receptor. I think that's probably why they chose that agent. But it also, has been utilized in other tumor types, but that's what it's called.
Okay. Can you talk a little more about how the NET tumor board works? What kind of information can a patient expect to receive after a tumor board consultation?
So, it's up to the physicians to decide who gets put on for review at the tumor board. It's generally intended for, situations where there's a question of what should we do, or in a particularly complicated case. We have the physician who's sort of in charge of the patient, presents the story to the group, and then poses the question sort of to be considered. And then we generally review all of the radiology associated with that patient's case. So we go over, CAT scans, MRIs, gallium imaging. Sometimes we'll look at pathology depending on the situation. And then because we're, all of the disciplines sitting together in one place, we're able to have a discussion about what's the next best thing. And then generally the physician who had, brought the patient forward to the tumor board would follow up with the patient to let them know, this is the nature of our discussion. This is what we talked about and what we're recommending. And then, and then we would implement that.
Thank you.
Mm-hmm.
Okay. We've had a question at some point in the group about genetic testing for family members, if there are any tests that can be used or not. And I think what the question really was is that if say this kind of cancer doesn't run in your family, but that somebody had cancer, should their children perhaps get tested, or are there tests available for that?
So there are specific diagnoses where genetic testing is definitely indicated. So, for parapheo, we would say absolutely. For patients with MEN1, we would say, yes, you should have genetic testing. But there are lots of cases where, there's not much known about, inherited disorders for bowel nets. And so usually if someone has a particular diagnosis that makes them at high risk for an inherited disease, or if they're of an unusually young age at diagnosis, then we will send them for formal genetic testing. Now that's different than doing genetic testing on a tumor, which we also do sometimes, especially for the high grade patients, not so much for patients with a grade 1 or grade 2 tumor, because we almost never find anything. But for the high grade patients, sometimes it can be helpful in guiding therapy. And that's where we would send like the tumor for genetic assessment. Otherwise, really what we just advise people is to say, your family members should just report to their primary care doctor or whichever physicians that they have a family member who has or had, a pancreatic neuroendocrine tumor, and just report it as a family history. But it doesn't necessarily mean that, that you're at risk for developing it or that there's a genetic element to it.
How many doctors are typically on the tumor board to provide feedback?
So it's probably, somewhere around like 8 to 10, I would say. I mean, there's always representation from medical oncology, interventional radiology, nuclear medicine, radiology, pathology, surgery, gastroenterology, nephrology, and often genetics. And so, and there could be, 1 to 3 participants from any of those groups. So, that it generally is the meeting size is around 20 to 25 people. But, there's, there can be, you mean like Bonnie and Diane attend as like our nurse navigators, and there can be nutrition there. We have some nurse practitioners who work with us. We have physicians who will sometimes come as like a guest if they, we have a collaboration with CHOP, with the Children's Hospital. So sometimes there are unfortunately children who get these diagnoses, and those physicians will present there. But yeah, it's generally around 20 to 25 people who are discussing the situation.
Wow. Okay. What is the best way to reach Diane and Bonnie? Email or phone? And what needs are most appropriate to contact Diane and Bonnie for?
So I don't know if either of them actually want to chime in and make any comments. Are you guys there?
I'm here. This is Diane. Either way, email or phone call, I will say for myself, an email, I will probably answer quicker simply because we're on the phone all day. So an email, we probably will answer a little bit quicker. We will answer either one. I'd also just like to add to part of what we offer with the program is that we do have a monthly support group, which is co-facilitated by myself, our social worker, and our dietitian. And so if you shoot me an email and you'd like to attend, I know sometimes patients like to attend more than one support group just to get more feedback. You can email me. I can add you to our mailing list, in which we have educational and networking sessions. So we will have our physicians present about every other month on their area of expertise. And then we follow with just networking, where the patients can talk about how they're coping and feeling. Some of the things that the navigators, the best things that we do to help with the patients when you contact us, I would say, is connecting you to all of those specialties, and we assist with scheduling. There's also some other nurses on the team that we call our triage nurses that will help with symptom management for those patients who are already established with us. Bonnie and I work closely together just in helping to get you to the right doctor at the right time. And we are in communication with the physicians of the team. Bonnie, you can add anything if I missed it.
That was very comprehensive, Diane. You can reach me by email or phone as well. My desk has recently been relocated and my phone line hasn't been transferred yet, but I will get the message if you call and leave me one. I do work closely with the Theo Para group and see all of those new patients when they come in. I will say for patients who are looking to come to Penn, a very important piece is to get your imaging on CD to bring or to provide to us, because just the paper reports are not always adequate enough.
Okay, thank you. Let's see, I did get Diane's email address when the slide was up. Bonnie, could you read me your email and then I will post it in our chat?
Okay, it's similar to Diane's. It would be my first name. I go by Bonnie, but my name is Bonita. So it's BONITA dot Bennett, BENNETT at pennmedicine.upenn.edu.
Okay, thank you. And your phone number also, I'll post that.
It's 215-349-5562.
Okay, I'd like to thank both Diane and Bonnie for being here today. And I want to be cognizant of Dr. Eads' time. I mean, it's a beautiful day here in Virginia. It probably is in Philly. So we need to wrap this up, I think, in a few minutes. And let's see. Okay, here's a question. We've had some members of our group that have had difficulty with getting approval for seeing specialists. And this is like people that have Kaiser health insurance. And do Diane or Bonnie have any suggestions for what they would need to do to get approval, from Kaiser to go out of network?
Is that also on Medicare? Are you saying, Sally?
Well,
Or private too?
Yeah,
It's
I think it's private. I think it's just generally Kaiser. Our folks with Kaiser, I'm not sure what their Medicare status was.
It may also be Medicare Advantage plans, which are narrow networks.
I will say for that, we are fortunate enough to have a financial advocate team that works with the physician side, the practice side, with working with pre-approvals, authorizations. As a navigator, we really don't have much to do with that. It's very complicated at times of what could be covered and what might be paid, what may need to be paid out of pocket. So we do have a team that we could ask for assistance with working with the different insurance plans to see. A lot of that would fall on the referring physician side of getting pre-authorizations. But if you do have like a tier level type of coverage that would cover some things, there would be an out-of-pocket piece. And then it also limits what could be done with that consultation. So sometimes it might be okay for a consultation, but if you wanted to continue care, that might not be allowed. So hopefully that answers your question.
Okay. Diana, I guess another question on the support group that you mentioned, and I'm not sure we were aware of that. Is that online or is that, how do you all meet?
Yes, so with COVID, we actually moved it to a virtual support group. Prior to that, it was in person and it was quarterly. So it was kind of, I call it the blessing out of COVID, because we were able, you know, a lot of the members were wanting to do something virtual. So in the midst of that, we knew that the patients needed a little bit more support. So we moved it to virtual and it's monthly.
Okay. Okay. Thank you, Diane. It looks like we've gone through all the questions. So, you know, again, I'd like to thank Dr. Eads, Diane, and Bonnie from the UPenn team for being with us today, sharing their knowledge and how things are done up at Penn. And we really thank you very much.
You're welcome. It was so nice to be with you today.
Well, thank you again.
Thank you.
Okay. And have a good weekend.
All right, you
Thank
too. We'll see you later.
Okay. Bye-bye.
Bye.
Okay, Sherry.